Hello everyone and welcome to BRAINCAST. This is Pospo from my headquarters, King's College Hospital. Okay. It's just an office, I know. And as every Monday, I'm here to bring you inspiring people from all around the world with one common passion, the brain. Last week, we traveled to Canada to meet Dr. Christian Schultz-Pack, a palliative psychiatrist at the University of Toronto. In a dark twist of fate, his camera wasn't working, but still we were able to listen to him as we explored the inescapable reality and destiny of all life on this planet, death, and the collective grief our society is currently experiencing due to the pandemic. This week, I don't have to go that far. I'm only walking across the road to the Institute of Psychiatry, Psychology, and Neuroscience to meet Dr. Marta Di Forti, one of the most prolific cannabis researchers out there. With collaborations that span the whole world, she managed to progress our understanding of cannabis and its effect on our mental health. Recently awarded the prestigious Medical Research Council Senior Clinical Fellowship Award, Marta has been running the first and only cannabis clinic for patients with psychosis. So, who best to talk about it? Marta, so good to have you here today. Rumor has it that they call you the cannabis lady. Is that right?
Actually, they call me the skunk lady, to be precise.
So, Marta, let's start with the basics. Cannabis. One substance, many actions, tons of controversy. I think that before we delve into the magic world of your research, it would be useful to start with some basic stuff. Let's go back in time. So, how long have people been smoking cannabis?
Well, thank you for having me here today with you all. And it's a very long story. And in fact, it's one of these stories that begins almost 3,000 years ago. In fact, in a very famous book of pharmacologists, which is the oldest in our history, which is the Pen Sao Ching, and forgive me if any of you know Chinese, I'm not sure this is the way you pronounce it, we do have traces of references to cannabis, and cannabis is referred as pharma, and actually pharma was something that in medicinal books was a compound that was known to have both medicinal properties, but also potentially to work as a poison. And what is very interesting in the history of cannabis is that in the very early times of this being used, people had a better understanding of cannabis than in the sort of 19th century, because along the complex history of cannabis, we have lost this idea that cannabis has got both sides of the coin.
Since you said that, can you introduce us to the cannabis as a molecule and its actions? Because it seems that it's not only one thing.
Well, cannabis is, first of all, when we talk about cannabis, so the cannabis that people use both for recreational purposes, so the one that's been exploited for pharmacological compound, we talk about cannabis sativa, which is actually an amazing plant. I mean, I'm not very good at growing pretty much anything, so I wouldn't get close to one. But I know a very talented botanicist who actually grows cannabis for one of the greatest pharmacological company in the world, and I've seen its greenhouse. And when you look at the plant, you actually ignore the leaves. The leaves of cannabis are useless in terms of where the active compounds are. But then you can see all this fluorescence in the female unpollinated plant. They look sort of very fluffy and sticky. And in this part of the plant, you have, if you look it with a microscope, you discover this amazing world of the trichomes, which are really very small sticky structure, which are filled with THC, CBD, and we'll see in a moment what they are, but also with at least another 200-300 compounds. So cannabis, which we reduced, at least in psychiatry and neurology, to just delta-9 tetrahydrocannabinol, THC, and cannabidiol, CBD, has got many more active compounds, which we still, for most of them, ignore the action.
Wow. So can you tell us a bit about the CBD and the THC? What are these things for people that are not really familiar?
So in some way, even first of all, THC was actually isolated in Israel by Professor Mashalom, and he is considered the godfather of cannabis, which for me is very relevant because being Sicilian, I'm quite respectable of this title. And he was the one that isolated THC for the first time, and he was the one that demonstrated that THC is actually responsible for the high, so for the sort of, if you like, recreational effect. And he did that in a very nice way. So he had never smoked cannabis, never has. It's now 88. But he wanted to really see, and as all pharmacologists would do, he decided to try it on himself and his colleagues, and got his wife to bake a cake with THC, pure THC in it, that he had isolated in his lab. And he did get high. So he knew that he was responsible for the first time. He was responsible for the high, and also effect on cognition and misperception. So they experienced sort of visual distortion and auditory hallucination, but mostly the key change was in thinking. So all they became very suspicious about each other, although they were very good friends and colleagues, which is really the core of, if you like, the psychiatric impact of THC, the effect on inducing suspiciousness and paranoia. CBD, or the knowledge we have on CBD are much more recent, and actually the Institute of Psychiatry has been leading on lots of experimental studies where people had been healthy volunteers. Some of them were our colleagues, Pospo. I wouldn't give names, but they were giving in one experiment THC intravenously, and it was very easy to recruit volunteers to do this study. They were queuing outside Paul Morrison office, who conducted it, and they were able to record how within half an hour from the administration, people who otherwise, if they'd been given a PANS, so a positive and negative symptom scale questionnaire, would have no psychotic symptoms, within a half an hour of THC would develop a clinical threshold, a significant clinical threshold of positive symptoms, primarily paranoia type delusion. And this would sort of disappear within 2 hours, although some of them did require medication, mostly benzodiazepine. And in a different experiments, the same group of people were given either placebo or THC, or CBD and THC. And the one that were given CBD did not develop psychotic symptoms. So if they had, they were fleeting and below a clinical significant threshold. So this began to suggest that the two not only had opposite effect, but actually that CBD could ameliorate some of the property or the psychotic inducing properties of THC.
Wow. Wow. So now one of the most important questions that in itself has caused loads of controversy over the years. So is cannabis addictive?
Well, actually, again, some of the most sort of significant work on this question comes from, around the corner, which is our addiction department at KCL, and is the work that Tom Freeman developed during his PhD at UCL and then brought along to King's. And he actually showed that indeed there is a very clear dependent syndrome that you can describe within cannabis. And I think why some of us have been fooled in relation to it for a long time, because cannabis half-life is so long and you can actually store THC in your body, especially depending from your BMI, up to a month. It's very difficult to have a sort of classic withdrawal symptoms kind of presentation. So you won't get what you see with alcohol withdrawal. You won't get the same that you see with opiates withdrawal because of the slow release of THC in the system. And this causes lots of confusion, but there is actually a withdrawal syndrome that you can describe, which it's associated with nausea, with significant variation in body temperature, and with confusion, with sweating, and with increased heart rate. So there is a clear now withdrawal syndrome, although much more subtle than what we use to describe. And people score the usual criteria. So all their life runs around cannabis. All the money they have, they spend. They destroy relationship. They lose their job. And sadly, on top of becoming dependent, they also can develop consequences in terms of decline, or if you like, deficit of cognitive performance. and also a proportion of them, although it's a small proportion, will develop psychosis.
I got it. So it is addictive. And I know it may sound a bit oversimplifying, but in my brain, it means THC bad, CBD potentially good, right?
Yes,
Good. So
sorry.
So moving past these addictive properties, though, there must be something about it, something about cannabis that makes people go back to it. So what is it that people tell you that they like about it? Why do they like doing it?
Well, one thing that they like is what Mushalom reported in his first experiment. They get high. In the young people I see, I primarily see people in the sort of late 20s who have been using cannabis since their teens, and they say that they can feel the music more. They can sort of they can almost experience at a tactile level the effect of music. They feel more creative, but at the same time is a high that is different from the one of other stimulants like amphetamine, because it's a mixed state where on one hand you feel high, full of plan and ideas, but also you feel chilled. So you get a sort of certain sense of detachment from the environment. You get close in your happy bubble, where the outside environment, with its good and bad, becomes quite distant. And this is one of the reasons the young people I see who also have developed psychosis in the context of cannabis use will tell me that even if they accept that sometimes cannabis can make their, for instance, auditory hallucination worse, when they use cannabis, they care less about them. So, and this is for them more important than having no hallucination, which is, I guess, from a clinician point of view, my goal rather than theirs. And so I'm learning a lot from the experience of the people I work with, because we have some ideas what cannabis does in terms of good and bads, but their point of view doesn't always entirely overlap with our objective, or if you like, academic perception.
So it sounds like they're enjoying it, but this enjoyment sometimes may come with some price. And I know it's not that simple, and you've already hinted towards it. It seems that cannabis can cause psychosis, right? So now last year you published a massive paper at Lancet Psychiatry. So 10 European and 1 Brazilian site, I really don't know how you managed all the admin stuff of all this, looking into the contribution of cannabis in the incidence of psychotic disorders. So tell me more about that.
So first of all, I'd like to say I played a very tiny contribution to an amazing study, and this was one of these examples that indicated me that if you want to do something that perhaps is meaningful with your academic time, you need to collaborate, and that was an amazing learning experience for me. Said that, what we were able to do is we were able to, with a collective effort of training everybody to administer the data in the same way and collect the data in the same way, to recruit throughout these 5 European countries, which in total were 17 sites, and Brazil, everybody who presented with the first episode of psychosis to a specific catchment area. And the other very unique element of this study is that we went out and recruited controls, which were not the classic friends and family of the academics, but these were people meant to represent the local community, what we call the population at risk. So if they had become psychotic, they would have become one of our case. So these were really representing what the population locally was about in terms of age, gender, ethnicity, and lifestyle, which was what it was very important to me. So when we analyzed the cannabis data, that is my area, or as you know, of interest, I wanted to look at simplifying the story, but to make it possible, to 2 main elements of what is the core of people pattern of cannabis use: the frequency of the use and the type, because the type tell us what we can expect in terms of the famous THC and CBD we just talked about. And what we found was that, first of all, in general, people who homogeneously, so across all these sites, if they were using cannabis daily and they were using a type of cannabis where we expected to be a content of THC of equal or more than 10%, they had up to 5 times a greater risk to develop a psychotic disorder. So in simple words, to be among the first episode rather than the healthy controls in the community. And then we were able to look what was the characteristic of differences in how many people in the general population of the different sites were likely to use cannabis daily or were likely to use high potency. And we found that those sites where there was a high proportion of daily cannabis consumption among the controls, so as a proxy for the general population, we had the highest rates of psychosis, and even more so for the high potency use. So more high potency use there was in the community, more cases of psychosis were presenting to the local mental health services. And of course, we control for the basic, for age and migration. We know that psychosis presentation can vary by age group, with the youngest being more likely to present with psychosis, and also by ethnicity. So this relationship that we found was independent of ethnicity, age, and gender. People will say, obviously, cannabis is by all means not a solo cause of psychosis, but it is a very preventable one. You can't reverse child abuse, you can't reverse obstetric complication, you can't change people's genetic pool, but you can advise them to modify a lifestyle choice like cannabis use. And so this is why I was quite passionate about focusing on this risk factor.
Amazing. And then, I think you're talking, with this passion about, one paper, and it took me like, let's say 1 hour to read it and, really absorb the results. But how long did it take to actually do the study? Because, people say, oh, it's a paper, I'm going to read it in like 5 minutes. How long did it take to actually do the whole study?
Very painful. So first of all, of course, the study started in 2011, and the actual recruitment of the cases. And so first of all, the application of the funding from the EU, because it was funding from the EU. So we started writing the application with all the principal investigator in 2008. So then get the money. 2011, you begin. You pull everything to everybody together. We did the central training in London, and I was involved in the training of the cannabis questionnaire. We had the wonderful thing is that we got to meet across the whole of Europe once every few months to say where we were getting on. So that was wonderful. And then, of course, we got the study finished. And in 2015, I was ready. I applied for some money to be able to fund my work. And in the application, I said, I'm going to use this amazing data set where the data are all ready and clean for me to analyze. No way. When I started doing that, I spent another year re-cleaning them because the sort of full of mistakes, which what you would expect from a multi-site center. And then finally, I started working at the analysis, and there were lots of sort of, when you work in a collaboration, you're talking about, I think we have at least 50 authors. So what you have an internal review before even you submit to a journal. So imagine waiting for 50 people to tell you what they think. And as you know, cannabis brings along lots of very heated opinion and disagreement, including among authors. So it took a while, but anyway, finally we submitted to Lancet, who replied saying, yeah, well, we had this before. You were published without something similar. Can't see anything novel. Rejected.
Wow.
So didn't take it. Wrote back and say, excuse me, this is the first evidence of an impact or a contribution on incidence of psychosis, which is one of the most debated questions. It's not been shown before. So the editor said, oh, perhaps you're right. And we started very painful sort of session of reviews. And finally, I couldn't believe when we got it accepted. So the learning story is that if you are passionate about something, if you think you analyze your data in honesty and that you have collected data that have a validity, do not give up, because editors are busy people. They might see your paper on a grumpy, rainy afternoon, and they might have not realized that can make a difference. So,
Marta, I would have quit back in 2011. I wouldn't have waited, but that's amazing. Wow. So you have been running, though, the first and only cannabis clinic for patients with psychosis in the UK. And it started back in June last year. So can you tell us a bit about what you do there before we continue?
So it's a very simple idea. I mean, I work in an early, in a first episode psychosis clinical services, in Lambert. And one of the reasons I'm passionate about this question of cannabis and psychosis is because 2/3 of the people that get referred to our service come with a history of cannabis use. And so it's really in your face among the risk factors that precipitate in these people that psychosis. And unfortunately, at least 45% of them continue to use cannabis beyond the onset of their psychosis. And one thing we do know, and this is uncontroversially the case, if you continue or if you start using cannabis after you have developed psychosis, this has a significant worsening impact on your clinical and functional outcome. So I realized that in our trust, we were doing very well for tobacco cessation. We have great links with our addiction services, but there wasn't anything that could be offered to this group to support them with making changes or even stop the kind of cannabis use if they wanted. And so I decided to put together what I know about First Episode and how to engage them together with the team where I work, with expertise from addiction. And we decided to ask for money from the Mosley charity for a very simple package of care, there was nothing new in it, except the novelty was putting together things that were coming from psychosis and coming from addiction. So we decided to have a sort of core assessment at the beginning where I see them with some other younger psychiatrists and more engaging with this group. And we cover some psychopathology, but one of the things we cover that I thought would have been a good motivational incentive was cognition. You know, we do the ACE3 that you're very familiar with, because these young people do not realize that their cognition sometimes is bordering with cognitive impairment for a pre-dementia screening. And these are quite bright people. If you actually do a full-blown IQ test when they're not intoxicated, they do very well. There's no cognitive impairment. And this is a very good way to engage the conversation with them. And also, we do a very detailed cannabis use, including how much they combine it with tobacco. Then they start a one-to-one intervention when they use motivational interviewing, as you know, gold standard in addiction, with contingency management, money, or voucher, I should say. Don't give money to people with addiction. And what we decided to do with the voucher was, rather than deciding ourselves what type of voucher, like Tesco, Sainsbury, each person chooses what voucher they want. We just set the amount. So this became meaningful to them. So to give you a snapshot, some of the people I'm seeing now in the clinic, one of them wants to buy himself a musical instrument. So it's collecting voucher that then he will use in a specific shop. Somebody wants his Oyster card topped up because, I mean, this was before the lockdown. They like to go out and about. Another one wants Amazon. Another one wants Apple iPlay or whatever. So this becomes relevant to them. And then we have a machine that can measure THC in your urine sample, so they can trace themselves with us how even dropping one joint a day can make a difference in that. And then I repeat my core assessment beginning, halfway, at the end, to show them how their score changes with the changes in the cannabis use. And then we have the thing, and sorry, I'm going over my 2 minutes, but this is something I really would like to invite you all to come. We have launched a peer group. So, you know, peer group or focus group at the fashion in psychiatry. And this is a peer group where you put together these young people who all have psychosis by definition, because they're under the care of our team, and they are using cannabis. And the way they interact with each other about their psychosis experiences, what cannabis means to them, how they're struggling with their use. And we have 3 mentors, which are 3 young people with a lived-in experience of psychosis who have stopped using cannabis. And we bring to them experts that will give a 10 minutes lesson on THC, CBD, the plant dependence, with a video, funky video with music on cannabis. And the way they really, I mean, I've learned so much from them that, you know, I think it would be worthwhile to see one of the peer group rather than having me talking about the topic. And people will learn so much more.
So Marta, let's move out of the clinic for a bit and take a look what's happening in the world. Society is not really clear what to do with cannabis, right? Legalize, not legalize. I did a really extensive search, meaning I visited Wikipedia, and there is this beautiful map of the United States showing the different laws and regulations that exist in all different states. In some states it's legal, some states it's not. Some states you can take it only for medical purposes and blah, 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 blah. So truth though is that there was a massive shift in the world's perception of cannabis, but most importantly, its availability after it started being legalized. So what should we do here? What should we do here in the UK?
Well, this is a question that I get often asked, and I give a very boring answer, and people don't call me back to ask again, which is I'm not, and this is, I mean, I truly believe that, I mean, I'm not a policy maker and I'm not by all means a politician. I think my contribution is really to share the data that come from my research or my experience to perhaps make sure that whatever people decide to do, they put out there enough and clear enough information so that people can make a choice and decide what to do with their brain when it comes to cannabis use. So personally, in relation to the option, I mean, the medicinal cannabis law, I'm very happy that cannabis is legal for medicinal purposes. I do believe cannabis can be exploited for medicinal reasons. I mean, most pharmacological compounds that we have known in the history of pharmacology have been used as medication. I mean, now we demonize opiates, but opiates, if used properly, are really still the most effective. I mean, if any of you had ever had a fracture or a trauma, they know that if we didn't have opiates, it would be much worse. Of course, then they get misused. So we are familiar to this. So, and I do hope that we will understand more and more to be able to use cannabis as a medicine
Hmm.
effectively. But to go back to the to your sort of ancient Greeks were used to talk about pharmakon, and forgive my pronunciation. And again,
So,
pharmakon were compounds who would have beneficial effect and side effect, or poison in those days. So I would like people to be aware that when they use cannabis recreationally in a legal environment, in a legal environment, my patients don't really care if it's legal or not. There are beneficial effects, there are even recreational effects, but also there are side effects. And unless people are aware of them, they will not be able to use it safely as a medicine or enjoy it properly as a recreational substance.
hmm,
And this is really where I
let's
come
And let's talk a bit about the pandemic. I read in the Financial Times that the sales of cannabis rose 159% in California by mid-March compared to the same period in 2019. In a Forbes article, it was in fact recommended that cannabis should be listed as an essential product and all relevant business should be left to operate, as it did in fact happen in San Francisco. I won't forget, it was a New Yorker article. And one cannabis related shop, she's the owner, the shop owner, he said, you feel there is responsibility to the public here. We're on the front lines. So, number one, have you noticed any shift in the cannabis consumption yourself during the pandemic? But most importantly, if there is such a high rise in people actually buying cannabis during the pandemic, do you think you're going to be a bit busier post pandemic?
Well, this is a great question. So, first of all, I can be rude about American because I'm Italian. So, American are so predictable. As soon as the pandemic started, I said, I'm going to set my clock to see how long they take to say that cannabis is the solution. And it didn't take sort of very long, at least in some states. Said that in my catchment area, which is very keen on cannabis usually, we saw something very interesting. So at the very beginning of the lockdown, the first 2 weeks of the lockdown, the end of March, we saw a quietening in the number of first episodes being referred to the team. And of course, there can be lots of explanation. But talking to my patients, I was very amused to hear that they were actually not able to get their cannabis. There'd been a sort of breakdown in the drug dealing sort of chain because of the lockdown. But of course, drug dealers, I think, feel like some of these shop owners in the state. They feel they have a mission in society. And so they got organized very quickly. And by the beginning, mid of April, we had a doubling in the expected number of cases that we see in Lambert during this time of the year, if you compare with previous years. So the answer to your question is, I was working at a grant application at the weekend. Well, the submission we did this morning is exactly to do this, to see if there have been any changes in the number of new cases of psychosis in our entire catchment area, the South London and mostly NHS Trust, comparing to a year before and a year after what it would be the end of the lockdown, and then to correlate this with any changes in the environment, including changes in the availability of cannabis. So I'm supposed to deliver the answer in 12 months. So in 12 months, I'll be able to say something about this.
Great stuff, Marta. Amazing stuff. So that's Marta Di Forti, people, and I'm pretty confident we will be hearing more of your work in the years to come. If you just joined, head to the Mostly Learning website where you can watch today's Braincast, but also the previous ones too. You can also check details of the upcoming shows, and trust me, there are a few surprises in there. So next week, we're jumping on the train to the mighty British North to meet one of the most well-known figures in psychiatry, Professor Wendy Byrne, the president of the Royal College of Psychiatrists. We'll be talking about the fascinating world of, I'm not going to tell you. Just join me next Monday at 1 p.m. Until then, Pospo for Mostly Learning. Over and out.
Thank you.